first. Okay, hold on just a moment. If you can just confirm that you can see everything. Can you see everything okay?
Yes, yep.
Okay, perfect. Okay, my name is Wendy Vieira. I'm Director of Operations for Behavioral Health with Neighborhood Healthcare, and we are a federally qualified health center in California. We are in San Diego and Riverside County. And today, last week, we focused a little bit on telehealth technology lessons learned. But this is more, I think, kind of a larger level, in general, lessons learned from the pandemic. And then really, what does our future look like? And where should we go from here, given all the lessons that we've learned? Let me see if I can get this to go forward. Okay, there we go. So I did want to throw out some numbers because I'm a data geek. And in the best way. I love data, and all of us had to do so much transition last year that I think it's important to just take a moment and breathe and look back and see what you've done and really respect the accomplishment, because I know we're not unique and that we're the only, I know all of you had to completely repurpose staff and how you did business and what you did. And I think it's important to look back. So just for us in general, like I said, we do have 18 clinics. In 2019, oh, I'm sorry, was somebody speaking? Nope. Okay, if you have a question, jump in. In 2019, we served about 76,000 unique patients. So in 2020 is not a huge difference. I mean, it's about 1,400 additional patients. But even though the approximate unique patients were the same, look at the visits. I mean, holy cow, that changed. We went up by over 25,000 visits. And then when I started looking at, again, kind of filtering back down to behavioral health and then the organization, when all of this happened, we had a ton of staff that had to furlough, some that were laid off. All sorts of things happened throughout this last year where even people for daycare and other reasons had to leave the organization. So with 100 less employees this last year, we did an additional 25,000 visits. And then when I looked at behavioral health alone, so our average provider, so our average behavioral health FTE did about 1,500 visits a year in 2019 compared to 2,400 in 2020. So that's pretty big. And I want to call that out. I think it's important to look at the numbers because there's more to this than we're going to start talking about all the lessons learned, but a big lesson learned is you have got to take care of your staff, not just your providers, all of your staff, all of your support staff. People are getting burnt out. And when you think about sustainable models, you better start thinking about this too, because this is incredible that we're all able to get so efficient and so lean and do everything that we did. But I do think you need to think in terms of being able to maintain this model going forward and how you might do it in a way that may support people more. So we'll move on. So I divided my lessons learned from the pandemic into 4 different categories. And this is more a checklist. I'm not going to read through them for you, but I kind of put it into, things you need to think about with your hardware, things, your software, how you might change your services, and then staff considerations. So hardware things that you could learn about, and I think this would much better prepare you for the future, is to think about stockpiling. And I don't mean huge stockpiles, but do stockpile some laptops, monitors, cables, everything, as you know right now, and I mean like anything, even if you're just doing work at your house, is difficult to get. Everything is backlogged and takes months and months and months to get. So, just to prepare yourself for that what if or that next whatever, one thing is we moved from desktop systems to laptops and kind of across the board for a lot of staff, including ancillary staff. And that allows us that even if they have their daycare shut down for a week or two, staff could still be active, so we were also able to change a lot of workflows so that we could repurpose staff to be working at home, because otherwise, if they had to go home for whatever issue due to the pandemic was coming up, that can throw all of our services just into a tailspin. And this way, if we're able to accommodate people at home, even on a temporary basis, that helps sustain all those services that we're providing. One thing that we also learned to do, we had a ton of tablets in each of our clinics. We were using them for screening, all of our universal screeners, for satisfaction surveys, things like that. So when the pandemic hit, we've got to think about how do we best utilize our equipment, because it was difficult for us to get laptops, and it was difficult for us to get a lot of supplies during this time. And so we put tablets on wheels, essentially, and we use them as telepsych carts. And this way we were able to wheel them in from provider to provider and have our MAs be able to have video visits with patients, do their med reconciliation, what vitals they could, and then wheel them into the patient, and then go take another one and work on sort of like, virtual rooming the next person. Those are things to consider. And then not only when you get laptops, but then you have to consider buying additional licenses for VPN access and remote access, and put that on those laptops. Otherwise, that's timely to get all that ready. We also just started using a lot of remote monitoring devices. I'm sure a lot of you are looking into that, but different ways that we can monitor our patients remotely. So I just put examples there of the glucometer and how we're measuring hypertension. Some software considerations real quick. There are a lot of platforms out there, so I'm not going to recommend one or the other. You'll have to figure out what's best for you. And honestly, we were kind of all over the place. We used Doximity, Doxy.me, Zoom, Hilo, I don't know, a bunch of them at different times. And they all had did different things for us. So you'll just have to kind of consider the fees. Some of them were free for us for a period of time. And then as soon as January 1 started, they started charging us after 40 visits. And then they shrink the time, so they kind of force you to buy the licenses. So, consider the costs, how many licenses you may need. Things to consider when you're thinking about software is, for the service that you're providing, how many people do you need to have in a room at a time? So originally we had bought a service that just had, ourselves and the patient. Well, then we needed an interpreter in the room, or their caregiver, or the MA, and it suddenly became more complicated. So we had to upgrade our licenses. So it's something to think about. And of course, make sure any platform you consider is HIPAA compliant. The other thing is to also consider how user-friendly the various platforms are, because some of them have been fairly complex for a lot of our providers who aren't super tech savvy. And so you need a whole team of people that can not only create these workflows screenshot by screenshot, but they can train the providers and then retrain and retrain and retrain, in addition to all the MAs and support staff that may use that platform. So keep that in mind when you're considering a platform that works for you, because a lot of them, there are several like Zoom that are just awesome, but they may be too complicated and have too many things that you don't need. So just consider that. So service considerations that we had to do. We've switched everything around, and thankfully in California anyway, with the emergency orders, it looks like they're not going away. I've heard in other states they have. So we have telephonic and video is payable at our regular Medi-Cal rate right now through 2022. And it's looking very positive that at least for behavioral health, it will continue. So service considerations are, what are we doing to provide service in a way that we can meet our patient where they are? We used to have about a 25-30% no-show rate prior to COVID. Excuse me. During COVID, we went as low as about, I want to say 7%, because now, of course, all of the individuals that we see have considerable financial challenges, transportation challenges, all sorts of social service challenges. And so when we were able to remove that by calling them, now we can call them in their home so that they don't have to make that choice between, gas money and getting here, or, taking time off their job or daycare, things like that. They can just simply pick up the phone. So service considerations too, we had to take time to have staff that would educate and train our patients on how to download the application that we were using, how to click on the link to get into the meeting. And then also we would train them on, you need to be in a quiet, confidential space for yourself, because with behavioral health, of course, we want to preserve their confidentiality as well. So we would not conduct sessions, for instance, if they're in their car, or you could hear children in the background, or they're at the grocery store, things like that. We would let them know they do need to find a private space and respect that time for that visit. Other things, Medication assisted treatment. I don't know how many of your programs do this, but we have a fairly robust program at our FQ. And this is the treatment for individuals with opioid use disorder and alcohol use disorder. And primarily prior to COVID, we were doing these inductions here at the clinic. And once COVID started, we were able to do home inductions. Now we do home inductions all the time. And the patient will simply come in before that first visit and have all of their labs done and the urine tox screen. And then we're able to conduct the home visit that day or the next day. We've also learned to do enhanced medical visits with our RN protocol. And so this might, we when you saw on that first slide where we're 100 staff down, we've got to make the best use and max everyone out at the highest scope and skill set of their license. And so, if there's some of those visits that could be that aren't necessary for primary care to see, that we could have an RN or someone else see, and then essentially conduct that visit and then flip it over to make that a billable visit. That's something to consider when you're thinking about sustainability. For us, we definitely invest in bilingual staff. So about 60% of our patients are monolingual Spanish. And we also have a very large Iraqi community that is monolingual Arabic speaking. So we have to think in terms of how do we make that work? Because we've used these, oh, I'm sorry, I'm hearing echoes. So we've used different interpreter services, and sometimes that adds an additional challenge when you're dealing with telehealth and you're bringing them into some of these rooms, because sometimes the connection will be lost. Either the patient won't have enough bandwidth, your provider won't, or you lose the interpreter, then you've got to call them back and start over again. You may want to think about, if at all possible in your area, invest in bilingual staff. They're priceless. The other thing we changed a lot of our services is that we're doing mobile health services. So a lot of what we had to do this past year was meet patients where they're at, which means meet them in their home. So we purchased, in the top right-hand corner, you'll see a car. We purchased 3 of our cars in different regions. We send our MAs out there, and they do all sorts of various labs and scans and things that to help a patient so they don't have to come to our office if at all possible. They also did the COVID testing and vaccination in someone's home. This was especially important for our seniors and really helped. These MAs also do well visits, health coaching, a lot of that. So I think that they are really great, especially for your geriatric population. I just wanted to throw out there, I did put a link down there. It's a YouTube link. We worked with the California Telehealth Resource Center, and this was just meant for our providers to have a provider-to-provider conversation about telehealth. So this is really just asking them, how was it for you at the beginning? It's, what did you struggle with? How do you do telehealth with special populations? So they're going to talk to you about, how to do telehealth with children. How is that different? How is it different with refugees with trauma, a lot of different trauma with undocumented individuals. And so anyway, if you're interested in those, they're little short 5-8 minute videos, and it really is just meant to be provider to provider to provide advice and quick tips. The other lesson that we learned that was huge for us is, and I can't overstate this enough, is you have got to coordinate and build those partnerships with your community-based organizations. They were lifelines during COVID and still are. And so when I mean build relationships, I don't just mean have kind of, you call each other back and forth or refer or coordinate care. I mean, write grants with them and start to think about how you can incorporate them in your services more. So a lot of what we did with our community-based organization, for instance, is we had to start thinking outside the box. Our biggest goal is, how do we remove access barriers for our patients? Tons of access barriers that were exaggerated and exacerbated by COVID. And so part of what we did is, well, what do we have? We have space in our centers. So we can provide space. We can bring those community-based organizations into our organization and co-locate them. And that way our patients don't have to drive all over. So we've done a lot of that, where I've taken some of our powerhouse community-based organizations. I've co-located them in several of our clients in our clinics. And then we've written several grants together. And then eventually we've put a clinic inside their main hub, which has been great because they serve homeless individuals, have a homeless shelter. So just anyway, things to think outside that. So other lessons learned with staffing, administration, administrative considerations. Tons of stuff. You need to have strong data informatics and IT team. You may want to think about tiering your IT team. so that for all your staff that are on telehealth, there's going to be tons of glitches, and you need to have immediate response and people that can resolve like simple issues to more complex issues. And then there are things going on with the EMR and analytics for reporting. I think it's important to invest in all that so that you know how you're changing services over time. So for instance, we look at how many in-person visits are we doing versus telephonic versus video, and we're looking how our services are changing over time. We also invested in scribes. So that's another thing to consider when we have 100 less patients and our providers are providing an additional 1,000 visits or more a year themselves. We don't want them burning out. So what can we do to help them? And some of it is we can have bilingual staff assist them. We can have scribes help type their notes. We can have language assistant vendors. We've also invested in having hybrid schedules for staff to help that burnout. We've developed several incentive plans for clinician burnout. Some are financial incentives and some are administrative incentives that will, like, so they can earn a scribe or they can earn block time off, things like that. One thing that we didn't know at first, but we realized quickly into telehealth is that we had to teach empathy to our providers. You kind of assume that they have that. It's different when you're over video, right? So or even when you can't see someone, that's even worse. That's more difficult. You've got to be able to, exaggerate the tone in your voice, or, how do you sound sensitive or sound empathetic and care? And how do you slow yourself down so that the patient can feel heard and connected to you, even though they don't see you? So those are some things that we brought in a consultant to help teach our providers. We also allowed our CME, CEU funds that we give providers every year. We allowed them to have flexible spending. So now those funds could be used to build an office at home, to buy a desk, a chair. What is it that they need? We use a lot of dot phrases or merge templates. Anything that we can do to reduce typing and clicking and mousing is really important to consider to make this a lot easier, and have like automated consent and limitations and automated documentation for telehealth. I think those are things that you can easily adapt and bring in. Other things that you need to consider with your patients and your platforms are the connectivity, the bandwidth. We talked a little bit about that last week if you want to listen to that video, but other things that we didn't consider when we bought our licenses was, well, now let's consider the impact of multiple users in everyone's home. So once we had figured out how much speed, and the bandwidth our provider needs, then we had to start and think about, well, what if their spouse is also working from home and they've got children at home, and same for the patients. And, so all that kind of goes down. Those are just things that you need to consider. We also had to utilize coordinators like crazy. So we repurposed a ton of our positions rather than lose staff that are used to having patient face-to-face jobs, that you can do a ton of stuff through coordinating and outreach. Let me just see where we're at. Okay, so this is my last slide, sorry. So where should we go from here? There's always silver lining in everything. This has been a horrible tragedy for all of us, of course, but there are also some incredible things that have come out for this. I mean, all of the health inequities that we knew existed before have been severely exaggerated during a pandemic, which is drawing so much attention, which is great because it's going to bring around change. And I hope that, things should never go back to where they are. So, a lot of this is, where do we go from here? We start to have a change in our culture. Now it's so easy for us to pivot. We never say, it's funny because prior to COVID, we may have said, oh, we can't possibly, or boy, that's going to take a long time. And we might have meetings for, several months to consider little changes. Well, we just pivoted on a dime. So now we know what we're capable of doing. So now we are constantly saying, how can we, instead of we can't, how can we, how can we make this happen? We're also including everyone's voice. We found the value in our frontline staff. They tell us, how can we make things easier? How can we streamline things? What are some job duties that you're doing that don't add value, and how can we get rid of those and streamline everything? And we also had to diversify the how, when, where, and who provides services. We provided services in our parking lot. Our community-based organization partners did the same thing. What services can we bring out of the clinic so that everyone stays safe? What kind of PPE do we need to consider so everyone's safe? the other thing, again, I said that our focus was on removing access barriers. So a lot of what we did, social determinants of health was more important now than ever. And so we had to keep screening through outreach because our patients weren't coming in the office. So we would do outreach. And we would have to help them with a lot of things that would get in their way, like the language literacy, transportation, daycare. We would provide Uber help. We had our mobile services that I showed you earlier, where cars will go out. We partner with our community-based organization to reduce those health disparities. So since we partnered with them, we would literally have them put our patients in hotels. They had sick and well hotels. They had a lot of money, at least in San Diego County, come through for this. We were able to house a huge portion of our homeless community for 6 months or more. And then the county had sick hotels that we quarantine people for. They also would deliver food, grocery bags full of food to homes, and they would call and they would have wellness calls that they would call into them daily. So there are so many different things your community-based partners can do that you don't. So just kind of think outside the box and get to know your community-based organizations and what they do, because there's a ton of in-kind resources you guys can share. And they certainly were just lifesavers for all of our patients. And they help with that integrative collaborative care model. I already spoke that we're looking at remote monitoring devices. And then the last thing here is the van that you see there. That van actually has 2 exam rooms in it and a bathroom. And we are now, it is now considered a satellite clinic. And so now this gives us the capability of, if anyone walks into that van, that is now considered a clinic, and we can bill at our Medi-Cal rate for that. So we're able to go to group homes, for instance, with severely developmentally disabled adults, to substance abuse residential treatment centers. We're doing a lot of that. And now we're also using it to go to the high schools to see kids. Let me see if there's anything else. Nope, that was it for me. So if there's any questions, feel free to ask. Otherwise, I'll throw it back to Kim.
Wendy, I just wanted to point out there are a couple questions in the chat here. One asks, what strategies have you employed to recruit and retain bilingual staff, especially in nursing? And then the other was about patients who struggle with technology.
Okay, so all great points. So a lot of our patients, I'll answer the second one first, just because it's easier. A lot of our patients that struggle with technology, most of them, to be honest with you, are our geriatric population, and we can explain, and it's just confusing. So in that case, because we're behavioral health, we do telephonic sessions. That's pretty much what we've done. We've tried to do groups. A lot of our groups didn't work for our seniors that we had. So we had people that would do how are you calls. They would do check-in calls to them all the time. They'd set them up with visits, but all the visits, the vast majority would be telephonic. For our bilingual staff, maybe it's because we're in San Diego right next to Mexico. It is actually not an issue for us to hire. In fact, the vast majority of our staff are bilingual. It is challenging for us to hire Arabic speaking staff, but we've kind of been okay there too. So I'm not sure what state that question was coming from, but being like 30 minutes from the border, it's lots of people are bilingual here. It's not an issue. That's not much of an answer, sorry. Otherwise, there are the services that you can purchase, the like in-demand interpreter services as well. Kim, were there any other questions in the chat?
No, I think that was great. We can go on to the next presentation.
Perfect, thanks so much.
Thank you. There's my children in the background, everyone. I'm homesick.
Can you see our screen? Okay, great, thank you. So hi, I'm Mary Zelazny, CEO of Finger Lakes Community Health, and this is Serene Garcia. She's our Chief Innovation Officer here at Finger Lakes. We are an FQHC in upstate New York, in the western part of the state, about 6 hours from New York City, so we're not close to the city at all. We're a typical FQ in that we provide, medical, dental, behavioral health, nutrition, care management, all that. We are funded for community and migrant farm workers. So we have extra money for our pop health or for our special populations. And we're also one of 17 migrant voucher programs in the US. So we've So what's unique about us up here is that even though we're in a very white part of the state, 94% white, a lot of our patients want to be seen in a language other than English. So it's really defined how we provide services. And to Wendy's point, we do have a lot of bilingual staff as well. We don't have access to them as they do in California, and it's very challenging to keep them on staff. So as we talk about telehealth, one of the beauties of having technology in your health centers is to use the technology to spread the interpreters that you have across your site. So there is opportunity there. So we've been doing telehealth we started in 2006, 2007, and then really ramped up in 2010. So we've been using telehealth for a long time, and we primarily started because we were trying to get access to care for our farm workers because we're very rural where our sites are. And it was very difficult for them to get to the specialists that we needed them to see. So that was our first foray. And we have grown since there. And the pandemic has changed somewhat how we do telehealth, in that it created the opportunity for us to move ahead about 5 years in 2 weeks. So it really pushed our very hesitant team at times to embrace telehealth because it was the only way we could get patients seen. So it's been a real game changer for us anyway, even in the beginning. It has saved us money. It has saved us time. We are very geographically challenged, and our patients have access to care. We also have been able to reach out to other FQHCs and other providers to share in some of their capacity so that we can provide our patients with the services they need and the language they need. So Serene's going to talk a little bit about our model, just to give you an idea of what we do with telehealth. So Serene, you want to talk about how we do this?
Yeah, great. Thanks, Mary. So like Mary said, we started to really ramp up our telehealth services back in 2010, and we started by inviting our external third-party providers to collaborate with us and see our patients. We had tried to bring the tertiary care providers on site, or that specialty work, into our rural communities, and there wasn't enough work, enough volume, so they would leave our facilities, and we were back to having to transport. So what we ended up doing to start off back in 2010 is that our mutual patients would come into our health centers. Here's a small picture of a health center that we have up in Sodus, New York. So the patient would come into our health center, and we would have a telepresenter present the patient to the distant provider. And the distant provider at the time was in a facility. We had restrictions where they couldn't be in their home as it is today, but they would be in their normal clinical site in their facility, which could be for us an hour and a half away. And the patient would come into our health center, where our telepresenter would use peripherals like the otoscope, stethoscope, general exam camera, use vitals, and telepresent to the provider in their facility. So we were able to bring in a room primary care and specialty care and provide that care to the patient in real time and be able to support each other in the work that's being done. A lot of the comments that Wendy made about ensuring that you have the resources within your community are very true even with this model, because we are in a rural area, so our local lab offices are not used to doing specialty labs or different type of specimen collection. So we had to have those conversations with those lab offices to ensure that they had the proper tubes, that they weren't concerned about billing. Some of these, for example, Hep C at the time, Hep C labs were very expensive, and the lab offices wanted to make sure that they were going to get paid. So a lot of community work and a collaboration between us had to take place, where we all came to the table and just worked together to address the barriers to care. So that's how we started with our telehealth work. And then we moved on to looking at how we could bring telehealth internally. So we had a hard time covering our 8 facilities. They're all in I think the closest ones to each other are like 45 minutes away from each other. So they're pretty spread out. So having one provider cover the need of the whole organization would be difficult because they would be restricted to either one facility, and it might impact another patient that could not do it on the day that they were there. For example, we have a licensed bilingual nutritionist, diabetic educator, and we were able to hire that person full time, and she would be able to cover all of our facilities by being able to be in one facility and seeing people in person, and then also being able to see people remotely that were in our other health centers. So we would have her be either in our facility or now today in her home as well. And the patient would come into our health center, and we would have that telepresenter similar to that external provider model, having the otoscope, stethoscopes, the peripherals, and being able to see the patient for that care. We also are able to take a staff person into the field, whether it's an RN or other support staff, depending as to what is being done for that visit, and telepresent to the provider with the peripherals that are needed so that they can have a visit in the patient's home, but having a telepresenter there to help facilitate that visit. So that's how we have been doing our internal, we call it internal within our own practice, telehealth services. Then once the pandemic hit, for us, it was really a life changer, like what Mary was saying. We were pushed many years ahead, particularly because we had the opportunity to have some of these telehealth restrictions lifted. Prior to the pandemic, we in New York were not able to see patients outside of our threshold. So the patient and the provider both had to be in our facilities for us to be able to either telepresent or to be the distant provider. You want to say something a little bit about that, Mary? So that helped us a lot to be able to move into that virtual world into the patient's home. So once COVID hit, we were able to make some quick adjustments and have our patients and our providers be in their homes and be able to have their visits. So for our early adopter patients that maybe had their peripherals, oral cameras or things like that, or wearable devices, we were able to leverage those resources during our virtual visits, and the provider could be either in the health center or in the home. So the telehealth experience for us was a little bit different from others. It was probably backwards, where we started external, then internal, and then went into the people's homes through virtual visits. Whereas I think a lot of the norm is that they start off with virtual visits, and now they're trying to figure out where else do we go from here? How can we weave in this care into our daily work and take advantage of this tool and resource that's here to support and enhance our current work? So Mary, can you talk a little bit more about how they can move forward with that?
Yeah. So, some of us have been doing telehealth, and some of you have been doing telehealth even prior to the pandemic, right? But a lot of people jumped into the game because they had to find a way to see their patients and pay the bills and continue care. And how do they do that? And they adopted telehealth. Unfortunately, one of the things that has happened though across the United States is you look at the data in terms of what kind of visits people had across the United States. A large portion of the telehealth work that was done during the pandemic and continues to be done is through phone calls, which is fine, except that it doesn't allow us to use the technology to its full extent. And I know for like our providers, I have had to say, you do not do a telephone visit unless the patient absolutely has no other way to get care, or we can't help facilitate them using the internet in some way, because we really, we understand that phone is it's a valuable tool, but we're really trying to move our team forward with video, because that is the wave of the future. And as we start to continue, in this country, as we start to build more telehealth capability, we have to be cognizant of that. And why is that? Sustainability. If we're going to stay in the game, we have to be using telehealth because our patients want it. We know that millennials, there's been 1 million surveys done. Patients love having that ability. Not every visit, but they really like to have that flexibility with telehealth, right? So that they can do follow-up appointments, some of their touch appointments, they want to have that ability. So there's a lot of patient demand. Sustainability means that we have to plan on our whole telehealth work. How are we going to weave it into our current clinical process? How are we going to train our teams to switch from an in-person visit to a telehealth visit and back again? How do we facilitate that happening in our centers on a long-term basis? And how do we get our staff comfortable with equipment and really using it to its fullest capability? So it requires planning. And a lot of us didn't have the opportunity to do that because COVID hit and we had to jump on fast. So, you know, we've talked to a lot of our peer FQs and have said, you know, take the time to go back and really look at how you do your work, because it's going to pay off in the end. You know, we have competition. We have competition from other FQHCs. We have competition from our insurers because they're doing, you know, after hours, if you have an earache or you have the flu, because they're trying to reduce their premium spend. So we really have to focus on how do we keep those patients in our virtual or physical four walls? How do we do that and make it a positive experience for our patients? And you know, keep in mind that for workforce, there's a couple of things that telehealth has really shown us. You know, it is fantastic for recruitment and retention because young providers coming out, if you can say to them, I have the cutting edge technology. What do you want to use? You know, how do you see patients? We offer telehealth capabilities in our center, and we would like you to be able to use it. And we have a really robust program that supports your work in telehealth as well as your in-person patient visits. That's a real selling point for a lot of young people coming out of medical school because they love technology. You know, they're so used to it, they don't even know it like an old-fashioned telephone is. So there's a lot of benefits to that, but also to take what you have as your workforce and spreading it around. We have virtual admin assistants that can answer phones and put a monitor on a desk at a site, and they can be a greeter even though they might be in another state. You can use your remote workers for all kinds of things. Interpretation, you can spread your workforce across your sites. Providers, we have providers where we've had one be sick, you know, they couldn't come in that day. We don't cancel patients. We have another provider see them using telehealth. And it doesn't work for every visit, but it really does help us. So, you know, we just want to start thinking about how things have changed and what does the future look like, and how can we incorporate our telehealth work in that and build our capability in order to attract and retain our patients. Okay, there you go, Kim. Back to you. Thank you.
Thank you. I have two toddlers who are homesick today. One of them is riding a horse. So it was a little loud here for a moment. Thank you for that great presentation. We are going to go now to Kim Schwartz, who is going to talk to us about her experiences in FQHC in North Carolina. First, I just want to check the chat. I see that there were some discussion and some questions about instructions for patients. And I know that we shared some of these resources from previous sessions in the resources section, but if there are cheat sheets or any instructions that you'd like to share, please feel free to share them with me. I'll put them up on the resources tab. Kim, are you available? Are you ready to?
I'm ready.
Begin?
Yes.
And just for those who, if you're able to stay longer than right at the 4 o'clock cutoff point, we can certainly continue to have this discussion beyond that for those that are able to stay. So Kim, I'll let you go ahead and take it away.
Thank you. And I apologize. I was supposed to be first and give the problem. and I had a problem with transportation. So there you go. I apologize to my co-presenters. Aren't they amazing though? Both Finger Lakes and Neighborhood have been doing incredible work for a long time. And we've been colleagues for a long time too, and in telehealth together. And so I was supposed to give the like how we do in Echo, I was supposed to try to give the issue and some of the structure. So I don't have slides. You have to look at me the whole time. So there you go. And what I want to talk about just briefly is you've heard some of the solutions. And so I do want to even put into the chat some of the things that kind of rise up for you as issues and problems, because you are living and breathing this all the time. And so we're also an FQHC in a rural area in Eastern North Carolina, where only 41% of our population have access to broadband. So you can see right there, I'm going to put that in the challenge, in the issues that I was just sending a message to a colleague of mine who's coming here to do some training for us. And I had to tell her, we do not have AT&T service here. You will go dead. We are a dead zone for AT&T. So the dynamics of being able to bridge the technology piece alone, I know that some of you are seeing, and we're, all these issues rose up, and we heard lots of legislators promise policy and funding, but I never heard anyone say, and if you have, you need to let me know, because I'm pretty well connected into the resource centers world about this, but I never heard anybody said, let's utilize access to broadband. No one really wants to do that because there's not enough money and revenue and resources in that at this point in time. But that is really some of the issues of equity to rural areas, and even to areas that have access to the cost of having telehealth and access to resources in the home. So this is kind of my section of what are those barriers that you and your staff are coming up against. So I can also address that. So for us, we're a provider of choice, FQHC, in a rural area. And so the majority of our patients are Medicare patients, so over half. And those folks do not, and they were grateful for that first contact in the first quarter of 2020. They were very grateful through June. And then they got frustrated in June of 2020, and the elderly folks who we couldn't get access to their home, and we did all those things that were the gymnastics of, well, maybe your granddaughter can bring her phone over to the house, or does she have an iPad, that she got from school, literally those were day before activities that we did early on to try to get access for folks so that we could see them, because there was just absolutely no way to see them in those early days. The other thing that we did end up partnering with our electric co-ops in the area was hotspots. The combination of the school bus programs that went to libraries and bank parking lots and school parking lots, and even in our own clinics. So all of our clinics we established as hotspots. And so folks came to the parking lot, stayed in their cars. The provider could have been even in the clinic, because still over 40% of our providers have no access to internet at home. So isn't that crazy to think about? So I have 44 providers, and 40% have no access to internet at home. So really challenging at that point in time. And so we did parking lot visits and drive up visits. And I think we're all still doing that, but the dynamic of those actually being fully billable, greatly accountable through quality improvement measures and peer-reviewed visits, so that we were monitoring the chronic disease all along the way. So that's an issue. And then and I think Mary mentioned this as well too, how to manage using telehealth as part of a routine plan of care. So we've got some research partners going along with us now out of Washington that are working with us on a diabetes work plan, so that a virtual visit is a part of the work plan. So that it's regardless of how it's paid or if it's paid, so that there's more points of contact to our diabetic patients and our high-risk diabetic patients. And so we're working on that to normalize that as a part of a flow, as both Wendy and Finger Lakes team mentioned, that's a big deal. We have these resources, we've advocated for them, and how do we normalize them? And I think that's the piece that I know after working with remote patient monitoring since 2006. So we were the first FQHC especially in the country that utilized RPM as chronic disease management. And now it's just it's very normalized, like, oh, that's what in the array of options for our folks. And again, still the battle of having the limitations of access. So I'd like to tell the funny story of a patient of ours that was a behavioral health patient that just wanted to be sure that they were seen and took a picture of themselves. They had to drive down their lane to be able, they waited till they drove as far as they could drive and got the picture on their iPad so that they could actually have a picture, not just the voiceover. And so that's a very common experience in the rural area. And I imagine that you all are having that as well too. And then I don't know if you all have experienced this, but the now at this point in time, the combination of virtual fatigue, so the meetings that we're all having, I don't know, we don't get to have large in-person meetings anymore. I'm sure you don't either. And so folks they are having that virtual fatigue. So, and feeling that it's inadequate in the personal communication piece. And so talking about how, again, to normalize that and make it feel routine and get over those providers that are just like, I don't want to do it. They're still that. They were grateful for it in the front end, truly grateful for it. But at this point, they say, that's not how we want to see our patients, even though it is how in our patients, some want to be seen and want that convenience. And so selling that and marketing that is really essential. Our organization is part of the IHI, Institute for Health Improvement Leadership Alliance. And prior to the pandemic, about a year prior to the pandemic, we started a group called Office Visit is a Dinosaur. We were called OVID before COVID was something. And that was in context to in some areas that we really need to bring it to the perspective of the patient first. In essence, or what I like to say, we're only patients when we're sick. The rest of the time, we're just people. Really bring it to the people first. What is it that, and how is it that they want their health care? And how can we make that possible? How can we make it feasible? And how can we make it, using Mary's words, sustainable? And as Wendy talked about, accessible. All of those pieces go into there. So asking that question from that real person-centered place. And so we set this amazing goal, which we thought our folks that were leading this were just off their rocker, and we set this goal, but within the first year that we would hit 80% of our visits would have access to virtual. Well, then COVID hit and we're like, well, who in the history of the world on this kind of audacious goal met it in less than 6 months? So how exciting that was. And now our conversations are around, okay, who is still using it? I don't know if you're answering surveys on the state and the federal levels, what percentage of are you using virtual now? And for our team, it's very little. It's where we flipped the switch around, where we were 80% virtual. And as Mary mentioned too, telephonic, to now it's the other way around. And the majority of that is behavioral health, and our annual wellness exams are almost all exclusively virtual under Medicare. And frankly, our 2 providers that are dedicated to that are not even in the state. So in Minnesota and Arizona. So we're hoping that the emergency order stays because that's helping us in our issues around getting provider care. So those are our big things. And Wendy touched on vendors and equipment, and that's all over the place. And then I will say, in the Mid-Atlantic Telehealth Resource Center toolkits, or in the website, you can link into a remote patient monitoring toolkit. It was done about 5 years ago as a part of a HRSA grant that we participated in because we've been doing it for so long. But some of the principles are still really there, and there's all kinds of documents that can be used in that. So I would point you in that direction, because both our team mentioned that some things sound easier than they are. There's all kinds of variables around instituting remote patient monitoring and the dynamics around that, and the vendors are all over the map. And again, supply chain is an issue. I know we talked about this in the prep piece. We are supposed to have a mobile unit. It was supposed to be here in February, and now it will not be here until January of 2022. So the supply chain issues on equipment are an issue, and that we're finding. We could get them, it's kind of ebbs and flows. I don't know. I see Mary nodding her head that it ebbs and flows for us. Sometimes that, oh, yep, we got it all. And then, oh no, we got everything but this peripheral. So I think probably some of you are coming across those challenges too. So I'm happy to answer any questions, and I know the team is as well here too. Aren't they amazing? This work that we're all doing together, and the really this frontier that we're in, and how we can make this make sense. So I think the thing I would say is it really takes all of us to advocate on the legislative issues regarding the broadband and the consistency. I mean, I'd really love to see a national policy on reimbursement so that we can guide that, because it is state by state. And I see Wendy's comment in there. Yeah, the California Telehealth Resource Center is amazing. That's a part of the Ocean Collaborative that we participate in, and they really amazing tools. And again, the resource centers, that's what they're there for, and the representation of the resource centers. So really need to say, don't try to go out there and invent things, because they're already invented in this in this world. So, and I apologize again. I had to go to Chapel Hill, which is 177 miles from here, for a doctor's appointment. So because we don't have many specialists, and they insisted on an X-ray. So, so good report, but it was a fast round trip and flew in the door today. So I apologize. I was supposed to be at the front end, but my gas tank wouldn't let me go without stopping for gas. So thank you, Kim. And I love hearing your children. Please, this is the sweetness of home. That's the sound of love to me.
Oh, yes, it's a loud bit of love over here. So I think we answered all the questions that were in the chat, but I want to give folks an opportunity. Any of our presenters, kind of last thoughts, last words that you'd like to share, or anybody who has joined, if you'd like to unmute, if you'd like to turn on your camera and ask a question, we're happy to.
I will say one consistency about all of us is that we all talk fast and like auctioneers, because there's so much information. So excuse the fast talk. All of us did that. And I was like, okay, there's so much to get in. So
you can listen to it on half speed when you come back to it.
I think one of the big things that we've always tried to say to others that are trying to build their telehealth capabilities is, reach out to people that have done it, because we've all done, Wendy and Kim and we at Finger Lakes, we've been doing this a long time, and we've made every mistake you could possibly make, and blunders and embarrassments. And, we're happy to impart all those to you so that you don't have to go through what we went through. But, most people that are really pretty proficient at telehealth are very willing to share their expertise. And then, of course, as Kim said, the resource centers are a fantastic resource for all of us. So use them and reach out. Feel free to reach out.
Well, just aware of time. We're very close to the top of the hour here. And we thank you so much for joining us, especially those of you who are able to join for all 4 sessions. Again, keep an eye on your email. You'll get a certificate of completion for this series, as well as an opportunity to give us some feedback about what you thought about the series and what you'd like to hear more of in the future. So thanks again for joining us. Thank you to our wonderful presenters for fitting all that information into this hour. And the recording, as well as the slide decks and other resources, will be available on the resources tab in the learning management system. So thank you so much. We hope to see you again for future sessions in another series. So thank you so much for joining, and we hope to see you again soon.